Thank you. So this is a broad topic, and as you've heard, we are to really lay the groundwork for the amazing presentations you'll be hearing in the breakout sessions. Just a full disclosure, I don't have any conflict of interest here. An overview of what I will discuss. You can read this faster than I can, so I won't be reading all my slides to you. That feels like death by PowerPoint sometimes when we do that. So terminology matters, and I love this quote: "Those who forget history are destined to repeat it." And we have a definition of chronic disease from HHS, and you can read that here. A year or more, duration, functional limitation, need for ongoing medications. And but an NIH-wide definition of chronic debilitating conditions in women does not currently exist. And I would also say at the FDA, where I was working with the Office of Women's Health for a couple of years, we did not have a definition of this as well. And the two terms that you hear and will hear throughout the conference today are unique terms: sex and gender. And sex is your biology, anatomy, physiology, chromosomes. It's usually binary, but not always. Gender is a social construct. It's how we are representing ourselves and to the environment, and how the environment reacts to us because of how we're representing ourselves. I found this graph many years ago, and it is surprising to me that in science, this is a Journal of Applied Physiology, that in this journal of really basic and translational science, the term sex in the titles of articles actually was about 50% in 82 through 85. We didn't see gender in those titles. But you see here in 02 through 05, gender is the predominant term utilized in the titles of articles. The journal did not change to a clinical journal or a social sciences journal. So what happened here? I think so societally and culturally, if you look in 82 through 89, that was really the rise of HIV. And I believe there was some sort of inherent and implicit move to say the sort of the less sharp term of gender. And when we do that as scientists, what we've done is we've conflated the science that we have. It makes it very difficult for us to aggregate scientific studies when we aren't utilizing the same terms. And also the fact that, as we heard and will hear, that we are taught to fix every variable in our scientific research platforms so that we don't have scattered data due to some conflated variables. But we also fixed sex and or gender at the beginning. So really hundreds of years ago, we teach that to our future scientists, that we'll go ahead and fix the sex and or not even consider gender. And so that will make your data look cleaner. We actually know now that is, that has led us to where we are today in 2021, still having these conferences and having these conversations. So what is the impact of chronic illness? From the CDC, we know that 6 in 10 adults have a chronic disease, and women are more likely to have multi-morbidity with chronic diseases. And you can see the diseases that are listed here at the bottom: heart disease, cancer, chronic lung disease. So it is a $3.8 trillion cost to the economy annually. So we see the leading causes of death here by sex. They are mostly the same, maybe in different categories for males and females, and then a few that are different. You see kidney disease and septicemia here for women. So not only is it important that we're talking about chronic disease and living daily with that, but we also have that as a large contributor to death. And we know, and I won't go into the economics and the societal issues and repercussions of the domino effect of losing that female or woman in the space in society and also in families, but it is devastating. And so we really need to address this in a really intentional way and begin to prevent death and chronic illness, or help women live better and more quality lives. So evidence is provided through well-designed, well-conducted research and optimal reporting of those findings. Healthcare is evidence-based. So patients bear the burden of our systematic failure to advance the knowledge and clinical application of sex and gender differences. And I want us to take a moment and just realize the end user here for us is the patient. Our patients are bearing the burden of 30+ years of us continually not intentionally addressing the issue of sex and gender and the importance of women's health research, its application, and the benefit to the patient. So thank you for allowing that for me to repeat that for you. So when I was at the FDA, I learned so much in my 4 years there, but I also began to hear time and time again, well, we don't have data on that, or we don't know that there would be this adverse event, an increase in women. And so I started looking at a model called biological plausibility. And what that says, and if you know that interim commissioner Janet Woodcock, Dr. Woodcock, who was the director of CDRH, CEDAR, actually kept saying to me as we met, begin with the science, begin with the biology. And so I started thinking about this, and it is no surprise that we have biological plausibility. And we can see it here in relation to inflammatory diseases and cancers. And in fact, in all of those chronic illnesses that I showed you on the CDC slide, we know that there are sex and gender differences in every one of those diseases, and that we have clinically meaningful differences. So I tell people that when I go to a cocktail party, I know so much about sex and gender differences. I can give, like, why men never remember and women never forget, or something funny like that. And probably things that aren't clinically meaningful that I have factoids in my brain about. But actually, there are clinically meaningful answers and evidence across every chronic disease that we are going to hear about today. And I think it's important that we recognize, if we rely on the traditional research pipeline to tell us in this step, cell, animal, human, population health, and clinical care application, if we rely on this biased research pipeline to get us to the point where we are really protecting women with research and not from research, then I think that we will have made a major step, because we may have clinical evidence of a difference, but when we move over, it could backfill, and retrospectively, our basic science colleagues, our translational scientists, we could work with them to actually design the study to say, why does this happen? And so I think that we can't really marry ourselves to this sort of longitudinal research pipeline. And some of that happens now, but it's not happening nearly enough given the ever-growing population of research that we have in relation to sex and gender. So research environments and expenditures impact the burden of chronic diseases. And I'm going to show you the NIH, with a $46 billion budget, works in the realm of discovery research and does amazing work. And then we go into product development, and actually pharmaceutical sponsors utilize some, a lot, of the work of NIH to actually build foundational work for new therapeutics. Then we move into product development, and then approval and post-market. And that's more in relation to industry and FDA. One of the issues I would have you just stick a pin in this is that when we silo data and we silo NIH and silo FDA, then we are not going to really reap the synergy that we could across those environments. So, for example, if FDA were to see a new class of drugs coming down the pipeline for new drug applications around diabetes, then going back as they were reviewing those new drugs to say to NIH, we don't really know, we don't have the science or research around this particular pathway, then could you help us fund some discovery research and really just work across that? And then for pharma, really to encourage pharma to do the analysis for sex and gender differences and to embrace it. If a medication, for instance, prevents stroke in only women and wasn't efficacious in men, why would we not market that? Women, have strokes at almost 50-50 according with men. And I think that we need pharma to sort of embrace that difference as well. So health policies which enable understudy and underreporting of sex and gender differences. I am fascinated by the 3 decades of work around this area. And so I wanted to share with you my experiences when I was at the agency and looked and reviewed policy and helped write guidance. And it really, the words that we use make such a difference. I'm not going to go through this entire pipeline. I think my slides are available to you, but there has been a lot of work in the area of women's health and sex and gender. And let me just give a shout out to Director Clayton, because she has been an amazing and will continue to be an amazing champion for many of these, and Dr. Vivian Penn before her, and Marcia Henderson at the Office of Women's Health at FDA. So these are really important progress that we have made, but let's talk about where we may not have hit the mark for some of these. So of course, everyone knows the 1977 FDA rule that women of childbearing age could not willingly even participate in early phase trials. That sort of propagated that bias pipeline that then I think insidiously spread across the research environment. Then the 1985 inclusion policy, basically, and I've underlined the words here for you so that we can all think about what we're writing and what it means. So the NIH inclusion policy was consider the inclusion of women, and general differences should be noted. And if women are not to be included, a clear rationale should be provided for their exclusion. And then in the GAO study, so the General Accounting Office performs requests and audits of usually out of Congress. Many times stakeholders go to Congress and say, please request this. And there was a lot of groundwork done by women and congresswomen that has actually moved the needle for us in health policy. So the GAO study for NIH in 1990 said, inclusion of women was not well communicated or understood within NIH or the research community. It was applied inconsistently among institutes and applied only to extramural research, not intramural. There was no readily acceptable source of data on the demographics of NIH study populations, and it was impossible to determine whether NIH was enforcing its own recommendations. So that was 1990. The FDA guidance, which actually guidance is just encourage pharma to do things. There are no teeth to that. And it encourages inclusion of women in phase 1 and 2 studies, expects inclusion of women, and expects analysis of data. Absolutely no teeth to that. So the 1993 Revitalization Act, NIH, said ensure that valid scientific analysis could be performed in determining whether differences exist. Include sexes in adequate numbers to ensure that data could be analyzed for an effect of gender on safety and efficacy. Then we have a congressional mandate come to bear for the FDA demographic rule that required sponsors to tabulate the data across age, sex, and race, and analyze safety and efficacy by age group, sex, and race in all new drug applications. So, and this absolutely is done at the FDA, but of course, pivotal trials are not powered, nor is there a percent requirement for women to be included in those trials. The 2000 GAO study, so again, another General Accounting Office study that came into place said NIH lacked protocols to enforce the mandate to perform and report valid scientific analysis of sex differences in late stage trials. NIH lacks adequate data tracking, and that lack of this compliance could significantly impact the ability to apply sex differences research to clinical management and outcomes. Remember, I talked about the patients are bearing the consequences of our inability to be very intentional in enforcing that we study, we publish, and we apply sex differences. So I'm going to move into the another audit. So I'll never forget this 2015 audit dropped at 5 o'clock on Friday before Halloween in 2015. And you know that any news that you drop on a Friday afternoon at 5 is where news goes to die. Like nobody looks at it. They want it to fall into the weekend and then people get inundated on Monday again. So really interesting about the timing of that release. But this GAO study said actually women were the majority of the clinical trial subjects, but that NIH does not track whether studies include plans for analysis by sex, lacks summary data to identify potential sex differences, limits assurance that NIH is supporting research that can inform medical practice for both men and women. This is in 2015. And the 2016 SABV policy, the editorial that came out in Nature in 2014 with Director Clayton and Director Collins was a happy day as I read that. But the SABV policy actually uses terms such as consideration of sex, may therefore enhance the rigor, expects that sex as a biological variable will be factored in, expects. And then but actually strong justification from the scientific literature must be provided for applications proposing to only study one sex. And investigators are strongly encouraged to discuss these issues with NIH program staff prior to submission. So that's the last policy I believe that I will review for you. And every policy that we've discussed so far has these words: could, may, and expects. So I tell people that if I tell my teenager, I expect you to do this before you go out with your friends, well, you know how that turns out. So Director Clayton, I believe, is such an amazing, transparent leader, publishing, and the Office of Research on Women's Health, publishing many reviews of their own work and their own policy. And this 5-year progress report and call to action actually led us to understand how the SABV policy has been taken up. And it has been over many centers and institutes, study sections. I've spoken to leaders of study sections. It's inconsistent, but definitely progress has been made in that respect. So I want to quickly just state for you that I was appointed to a congressional task force as the proxy for the commissioner on the task force for pregnant women and lactating women for research into pregnant and lactating women, basically the Preglac task force. And this was led by NIH. And I just wanted to share with you that I offered the stakeholders to perform an audit. FDA would perform an audit of all of the drugs that had moved the labeling from the ABCD format to the new label that gives a lot of information, but no letter anymore is used for whether it's safe in pregnancy or in lactation. And what I found was that of the 575 prescriptions, 72% had neither human data about pregnancy or human data about lactation. This is 72% of 575 drugs, which could be used in pregnant women or lactating women to treat diseases or to enhance their health. And we have zero human data. And from the previous speaker, I mean, we are in a crisis at this point, and that does need to be changed. So again, quoted by many, we continue to protect women from research instead of with research. But NIH, ORWH cannot advance the health of women alone. And true progress is going to require change across many organizations and institutions. And I believe that collectively, as a community around women's health and sex and gender, many of those listening here have been instrumental in moving the needle. And I don't want you to take away from this that this has all been negative, because even though we are using these terms that do not have real teeth and repercussions to them, we have made significant progress, but we need it to move faster. Science is moving faster, so we need to move faster. So these are all the points of engagement that we can, that have to be addressed. And I would encourage you to take this graphic and look at it and create one of your own in your environment, because the internal circle is in my institution. External are all of these external entities that can help us achieve success. So more women are participating in research, but without marked progress in outcomes and clinically meaningful knowledge of sex and gender differences. And just having a little bit of technical issue here. And the fact that we use this language shows that when things are optional, many researchers will opt out. So that is the bottom line there. And it causes inequity in the application of scientific discovery across research and clinical care. And a call to action is for us to advocate appropriate use of terminology. Health policies need to include specific language and actually have repercussions for not following those. And a periodic reporting by NIH and FDA of objective progress, not because you get audited, but because we want to be transparent with the community and the populations that are affected. To adopt a definition of chronic debilitating disease in women for NIH, we need to be able to track it. We know we have lack of data tracking and capability in NIH. That needs to be addressed. Basically, NIH needs more funding and FDA needs more funding around database, expanding their IT environment. And to allow tracking of funding by codifying this variable. And then crucial environments where I think we could be even more intentional is with Congress and with the pharmaceutical industry, and not really leave it and expect our federal agencies to really do all of the heavy lifting around this. So I believe, Sarah, that this is my last slide, and I hope I ended right on time. I promised you I would.